Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode.
Hello, everyone. Welcome back to 10 Clinical Minutes. As part of our OB series, today we'll be talking about inductions of labor. So just some quick facts. Oxytocin, also known as Pitocin, was first used in 1948 as an adjunctive agent for pregnancies, for deliveries. Also, the rate of labor induction has more than doubled from 1990 to 2006. Currently is almost a quarter of live births in the U.S. And then lastly, Laminaria japonicum, which is kelp, can be used for induction to ripen the cervix, but has a higher risk of infection. That was maybe the most interesting fact I discovered in the making of this presentation. So what are some indications for induction? It's always a good question to know if we're going to do a procedure, what are we going to do? So you have maternal indications such as gestational hypertension, preeclampsia, eclampsia, postpartum pregnancies, abruptions, premature rupture membranes. And you can do logistical concerns of greater than 39 weeks, which can include anything from mom being out of town to the OB being out of town. Then you have fetal indications for macrosomia, gestational diabetes, which can cause macrosomia, or placental failure, chorioamnionitis, fetal growth restriction, isoimmunization, or oligohydramnios. All of those would be indications for induction and would be caused to induce. After that, you have to decide, are we inducting, or is this severe nephrotic dissection? But today we're going to focus on normal inductions for vaginal deliveries. So contraindications, they're the same as the contraindications to a vaginal delivery. This is a non-inclusive list. So these things can all be reasons you would not do vaginal. There are other things that can. Notably, the previous classical C-section, that's with the incision that's made vertical in the uterus, not the normal low-lying incision that's made. And then active genital herpes can be transplanted, or if it's category 3 fetal heart rate tracing, as we discuss on our fetal heart rate tracing videos, that is an indication for an emergent delivery, and thus a C-section, not with the time to go through the labor process. So where do I start? Good thing there's a scoring system. This is the Bishop score. All these components go into it. If the score is greater than 6, then you have a favorable induction, and you can start with oxytocin. If the score is less than 6, you have an unfavorable induction, and if you just started with oxytocin stimulating contractions, you would be unlikely to achieve the vaginal delivery, unless you start with cervical ripening. So we're going to start talking about cervical ripening for Bishop scores less than or equal to 6. So the goal here is to induce the normal process that undergoes in a normal spontaneous labor process to remodel the cervix, making it softer, causing it to dilate, and causing it to efface. Physiologically, that happens as collagen breaks down, white blood cells infiltrate the cervix. You have cytokines, and then you have glycosaminoglycans, the GAGs, alterations that cause it to be able to kind of be like a donut that squishes thin, spreading out the gap in the middle, and then also spreading out the amount of ridgeline on the edge. Normal cervix is 4 centimeters. By the time you deliver, it'll be almost non-existent. So there are a couple agents we can use for cervical ripening. The first of these is a Foley balloon. You can put in 30 to 80 mils of saline. It's very cheap. It can be used in outpatient. It does not induce contractions, so you have no risk of tachysystole. But you do have an infection risk and a bleeding risk, which is why some women are prone to not want to do them because they don't want something inserted. On the other hand, it immediately falls out whenever you get to the 3 centimeter mark, telling you where you're at. You don't have to monitor or check a woman's progression because you have this built-in mechanical system to tell you when you're at 3 centimeters. The balloon kind of acts like the baby's head, putting pressure on the cervix, causing it to change, and is a great tool. Also commonly used is misoprostol, known as Cytotec, dosing 25 micrograms. If you get up to 50, then you start to have more of the tachysystole. Cons of this is that it's non-removable. Once you get the medication, it's there. You can't get rid of it. It's cheap and it's safe, the 25. It does induce labor, so you can start to have some contractions with it. And there's a risk of uterine rupture, and that goes along with the risk of tachysystole. And then lastly, you have dinoprostone, also known as Cervidil. It comes in a couple different formulations. One is a gel that can be inserted either into the cervix or the vagina. And then one is a little insert that you can put in, and then that can also remove. It also induces labor, so it also has a risk of tachysystole. It actually has a greater risk than the misoprostol, and it's more expensive. But the benefit is that you can remove them. So some agents that we have for this, you have a Foley balloon that can insert in the cervix. is less than 3 centimeters and no call out. And then you have misoprostol, which you administer 25 micrograms vaginally. This is what the tablets look like. It also comes in 100 milligram, or 100 microgram, 200 microgram. And then you recheck the dilation 2 or 3 hours or whenever the patient becomes more uncomfortable. So once you're at a favorable cervix, which would be Bishop greater than 6, you can start to induce labor. In yellow are the most common interventions. One of those is oxytocin, the other is amniotomy. This table kind of describes some of the pros and cons. I'm going to focus on oxytocin and amniotomy because those are most commonly. So oxytocin mimics physiological labor. You can titrate it up and you can titrate it down, but you do have risk of tachysystole, of rupture, abruption, or fetal heart rate change. And you can also have maternal hypertension with it. The amniotomy is a good adjunctive, not good for solo use, but it does come with the risk of prolapse, cord, vasoprevia, cord compression, and increased risk of infection. Membrane stripping is commonly done in outpatient intervention. And then the last you can use in a low-risk setting that has not been studied in high risk. And lastly, here are references, ACOG's Practice Bulletin 107, and then the Little Red Book, James Comprehensive Handbook of Obstetrics and Gynecology. Thanks so much for your time. If you have questions, let us know. Enter the Decoding and check out the other review videos in the series.